Podcast is now starting. All attendees are in listen-only mode.
Hello, everyone, and Happy New Year. Welcome to CFN's webinar series. Today's topic will be on elder-friendly approaches to the surgical environment using biological samples to samples to identify and provide optimized care, also known as EaseBio. Our presenters today will be Drs. Rachel Kadaroo, Amrit Buehler, and Ahmed Negam, all from the University of Alberta. My name is Jeanette Prorock, and I'll be hosting your webinar today. As always, please feel free to type in any questions you have into the chat box, and we'll do our best to answer as many questions as time permits following the webinar. At the end of the webinar, you'll see a survey pop up on your screen. Please fill it out as it helps give us feedback on how to improve our webinar series. Particularly important today as we'll be trying something new with having our presenters visible to you on webcam. The webinar slides and the video itself will be available for viewing online within 1 to 2 days after the webinar, and you can find that on our website under News and Events Webinars. A quick note, our next webinar will be taking place 1 week from today on Wednesday, January 22nd, same time, 12 noon Eastern Time, and the topic of that webinar will be supporting quality of life assessments of frail older adults and their family caregivers, and that will be presented by Richard Sawatsky from Trinity Western University and Kara Schick-Makarov from the University of Alberta. And you can register for that again on our website, cfn-nce.ca/webinars. So a little bit about our presenters today. As I mentioned, the topic today will be on their project EaseBio, which was presented at CFN's national conference this past fall and was selected as People's Choice Conference Storyboard. The first presenter is Dr. Rachel Kadaroo. She is Associate Professor, Intensivist, and Surgeon Scientist at the University of Alberta, and she has obtained almost $3 million in national funding for her work. Our second presenter is Dr. Amrit Buehler, who is a postdoctoral fellow at the University of Alberta. He has recently completed a PhD in nutrition and metabolism at the University of Alberta. And our third presenter today is Dr. Ahmed Negam, who is a postdoctoral fellow at the Faculty of Rehabilitation Medicine, University of Alberta. He recently completed his PhD in rehabilitation science at McMaster University. So with that, we'll turn it over to our presenters to speak to us about EaseBio today.
Hello, everyone. Thank you very much for that introduction, Jeanette. And we want to thank CFN for having us be the first ones to kick off your webinar series of the year. So Happy New Year to everyone. And we thought that we would share who we are, so hopefully you can see us on the webcam, and I definitely cleaned up my office for all of you before I came on. The other thing I learned, Matt and Jeanette, is why CFN does all the webinars, and it's because you don't want to come to Edmonton, Alberta to see us. Yesterday was a good day. It was only -35. Today we are at -37, and with wind chill, what did they say it was?
It's like -52 or something.
Yeah. So enjoy our webinar from your nice warm homes and offices. So today we're going to share with you elder-friendly approaches to the surgical environment using biological samples to identify and optimize care. And this was supported by CFN, and we want to thank you so much for your support, and you'll see lots of other support within here that has come and worked together with this project. So for our outline, we'll start off with our background and discuss with you about elderly patients undergoing surgery, look at surgical risk assessment tools, and look at CT imaging as an assessment tool. We'll look at our EASE study results and design, our EaseBio study results and design, and look at ongoing future direction for our group. As all of you know, seniors constitute the fastest growing population in Canada. Nearly half, 1/3 to half of all operations are done in patients over the age of 65. Abdominal surgery specifically has increased from 20 to 28% in the years that I showed you here. And in Alberta, in just last year, there were nearly 300,000 operations. And just to give you a picture, that would mean that 100,000 to 150,000 operations in our province were just in older patients alone. Data from our group and what's known from other literature is that almost over 50% of patients develop at least one in-hospital complication, and about 30% of elderly patients are discharged to an institutionalized care facility after their surgery. So this slide summarizes what I have just said, that we have older patients coming into hospital for surgery. We know they have increased complications and infection, increased length of stay, increased time in ICU, increased risk of mortality, and ultimately this increases healthcare costs. My MSc student and surgical resident, who is a fellow now at McMaster doing pediatric surgery and was supported by CFN, did a review of risk assessment tools to predict morbidity and mortality in older surgical patients. And from this review, we found there were 13 risk assessment tools identified. But some of the challenges in it is really having a clinically relevant surgical risk tool and one single one that could match needs. Many of them are complex. They require a lot of parameters when you actually have to put them into calculators to figure out what the risk is, and or are subjective. And even to this day, before we do surgery, I'll say very rarely are people typing in risk assessment tools and using them to discuss them with their patients. But let's look at objective surgical risk assessment tools. Sarcopenia, as most of you know, is progressive generalized loss of skeletal muscle mass. Muscle is aggressively broken down during critical illness, and up to 5% of muscle is lost per day that a patient stays in bed. In the cancer literature, we know that sarcopenia leads to increased complications, extended ICU stay, longer length of stay, and mortality. But little was known about our emergency general surgical population. And in 2014, we published in Surgery and specifically looked at sarcopenia as a predictor of outcome in our very older patients, meaning greater than the age of 80. We had a CT scan that was done already because of their their emergent surgery that was happening, but as long as it was within 30 days, we included them in our study. Their age average was 84 in this study, and you can see it was a good ratio between males and females. Importantly, when we looked at CT images, 73% of them were defined as sarcopenic. And I'm going to highlight something for you, is that definition of sarcopenia actually stems from cancer literature. And later on, Dr. Negin will show in his slides how maybe this may not be completely accurate. But for what we know now, our gold standard definition of sarcopenia, there was 73% in our emergency surgical population. Here, when we look at the outcome of sarcopenia on our surgical population, is you can see here that 23% were died in hospital if they had sarcopenia, compared to just 4% if they weren't sarcopenic. And again, with postoperative complications, 45% if they were sarcopenic versus 15% if they were non-sarcopenic. It shows you that older, frail patients with sarcopenia have increased risk of poor outcome following surgery. What we wanted to do was see if we could intervene on this. And one of the methods we took to do this was a clinical approach. And we did this with our EASE study, Elder-Friendly Approaches to a Surgical Environment. We hypothesized that doing a bundle initiative would improve morbidity and mortality. So what this initiative included was capacity, realignment, having all our older patients, we tried our best to have them in one ward. We did interdisciplinary care, which specifically meant we added a geriatrician to the team. We implemented evidence-informed practices with an order set, and we did our exercise Be Fit reconditioning program that I'll share with you in a few more slides to come. And we did early discharge planning. And our study methods here was any patient over the age of 65 who was referred to our emergency surgical service and had abdominal surgery. We excluded them if they did not have long to live with palliative surgery, if they were multi-trauma, or had dependencies greater than 3 and were living in a nursing home, just because we wouldn't be able to intervene or change their potential outcome. We screened almost 7,000 patients in this study, and it got us to a number of 684 that we included into our final EASE study results. We followed our patients in hospital for many of their outcomes, including complications, length of stay, hospital mortality, and discharge disposition. We also followed them as an outpatient in their 5 to 6 week follow-up with their surgeon for sit to stands, timed up and go, and health-related quality of life. Also, some of the data that we show you is the sit to stand that we did just prior to their discharge of hospital. I'm very pleased to tell you that as of February 12, 2020, our EASE study will be out in publication in JAMA Surgery. So I hope all of you can take a look at that and see the details. But to summarize, we had the patient population that I described to you, and we had 2 sites, a control site and an intervention site. Our control site also, we collected data pre-EASE and post-EASE. And here at the University of Alberta Hospital, we applied all of the interventions that I discussed in a prospective before and after study. Our outcome at the control site had no change in their clinical outcome. In the intervention site, we had a significant decrease in major complications and death of 19% and a 3-day decrease in length of stay. Now, more detail on our BFIT program. On a subpopulation, we examined how the effect of our independent reconditioning program had on our patients. And what we found was that patients who did the BFIT program had improved sit to stands, as you can see here, before their discharge from hospital, which was significant. And when we saw them in our surgical follow-up clinic, they had improved timed up and go, where they walked 10 feet and returned and had decreased time to do that. So we can see our exercise done independently by patients at bedside improved their function and was safe and effective. Now we really wanted to link this with what was the biology of the patient's muscles. And we did this through the support of CFN. To date, there had never been any studies evaluating muscle biology in our emergency surgical population. We were interested in understanding how the overall muscle characteristics could actually then impact surgical outcome. That could impact potentially at surgery. We could apply novel treatment strategies and specifically personalize medical care to a patient if we knew specifically what were their own biologics that could influence their surgery. And again, as I mentioned, CFN supported this study, and we'll show you what our approaches were to look at the biology of our EASE patients. We did first CT-derived muscle assessment, and here we combined looking at muscle quality and muscle mass as measured by CT, and we looked at clinical outcomes. Then our second approach was looking at muscle biological characteristics. And what we did was biopsies that were taken just at the time of surgery after they were asleep and obviously consented. And I will pass this on to Dr. Negam to continue.
All right, thanks, Rachel. So here we're back to the EASE study flow diagram. And of all the included participants in the EASE study, we have 335 CT images. And we also collected 54 muscle biopsy that's obtained from the rectus abdominis muscle during their surgery. And we collected the CT images and muscle biopsy to see because we want to know how muscle criteria is kind of change the outcome of these participants. And as Dr. Kedra mentioned, sarcopenia is one of the major predictor of the unfavorable outcome in this population. Not only sarcopenia, which is defined by skeletal muscle mass, but also another variable that's been shown to be predictive of unfavorable outcome was the muscle radiodensity. And muscle radiodensity is always an indicator of the fat infiltration of the muscle. And as we mentioned before, in cancer patients, it was shown that sarcopenia or low muscle mass and low muscle density has been associated with mortality, postoperative complication, extended ICU stay, and also longer length of stay in the hospital. But as we said, in the emergency surgery population, we don't have any information about these two parameters. Why we're using the CT image to measure the skeletal muscle? There's a few reasons for that. First, CT is a gold standard method for diagnosing sarcopenia and measuring muscle mass and radiodensity. Second, most of the people who are going for emergency surgery, especially the older adults, they already had CT before surgery. So we're using this already existing resource and CT to try to estimate the muscle mass and muscle radiodensity. Last reason that we know that if we measure the muscle cross-section area at the lumbar, at level of lumbar tree, it's highly correlated with the whole muscle, whole body skeletal mass. So if you measure muscle cross-section area at L3, we can predict or estimate the whole muscle, the whole body skeletal mass. And this is a slide of one of our patients. As you see here, this is at L3 level. And you should see the colored area here. It indicates the muscle surface area that we can estimate for this patient. Not only we can estimate the muscle cross-sectional area, but we also can estimate the muscle radiodensity from the same slide. So if you look at the left side here, we have a participant with 49 Hounsfield unit, which is the unit for the muscle radiodensity. So, and you look at the color here, it's mostly red. And as you look at the index above, red is mean high radiodensity. And if you look at the other side, on the right side, you'll see that's muscle with 10 Hounsfield unit. And you'll see most of the muscle area is blue and yellow, which indicate that this muscle is low radiodensity. So here I'm gonna present from now and for the next few slides, I'm gonna present a few preliminary results from our EASE Bio study and related to the CT images. So to date, we completed about CT analysis for 195 participants. We're still ongoing on that, so we're gonna do some more. But of these 195 participants, we have a quick description here about the muscle cross-sectional area and muscle radiodensity. As you see, the cross-sectional area of the muscle is 110, and the radiodensity is 26.2 Hounsfield units. When we look at the cancer patient or cancer literature, as Dr. Kadro said, it's we use the cutoff points from the cancer patient, but are they similar? This slide shows no, because there is a big difference between the cross-sectional area, muscle mass. It's 110 in emergency surgery and 132 in cancer patient. Muscle density is pretty similar. It's 26 in emergency surgery patient, but 35 in cancer patient. What that tells us that maybe the cutoff points or the diagnostic criteria of sarcopenia or for developing cancer patient, maybe it's not valid or applicable for people going for emergency surgery. So that's our next step. Actually, we're gonna use our large database, our large number of CT analysis, and develop the cut points to diagnose the sarcopenia and identify sarcopenia in older adults who are going for emergency surgery. And this is a few. This is again some of the results. So because there is 6 difference in the muscle features, we use the female participant in the EASE Bio study to show you some muscle characteristics. Some participant characteristics, and we also split our sample into around the median of muscle radiodensity. So we have low muscle radiodensity group and high muscle radiodensity group. And the purpose of that is to show how different the muscle radiodensity make in the clinical outcome. And as you look here at the age of the group, it's the mean age is 75.8, and you see there is no difference between in age or clinical frailty scale or comorbidity. but there is a little difference in the BMI and the number of medication between low versus high muscle density population. When you look at the body composition variable, you see there is a difference between the group in visceral, subcutaneous, and total adipose tissue, and of course it's higher in the low muscle density group. This is an exciting part. So when we link these CT, like the muscle, the radio density, to the clinical outcome of these patients, we found actually that there is patient readmission is very, very high in the people with low muscle density. It's about 59%, compared to the people with high muscle density, only 9%. This is a huge difference in such a small sample, but it indicates how important the muscle density is in predicting the unfavorable outcome. Also, at discharge set to stand, we found it's lower in the people with low muscle density, only 1.6, compared to 5.3 in people with high muscle density. Also, the health-related quality of life measured by EQ5D, we found that it's lower. It's lower in the people with low muscle density versus high muscle density. So that was our results from the CT image and how we linked it to the clinical outcome. And now we're going to talk about the muscle biopsy results, and Dr. Buller will take over from here.
Thank you. So in the second part of the study, we collected 54 biopsies from these patients, and I'm going to show some key features of these muscles. So one feature which we looked at in these muscles is the fat content of the muscle. As we know, that fat content is associated with the low muscle radiodensity, and another two features were the fiber size and the fiber type. And we know that with aging, this fiber size and type changes with age. The fourth feature which we looked at was the centrally located nuclei, and the location of the nuclei is important because it is used as an indicator of a myopathies in different diseases. So similar to what Dr. Ahmed presented, we split the patients into two groups, one in a low muscle radiodensity versus high radiodensity. So somebody with a low radiodensity had a higher triglyceride content or the fat content, and also we found that low radiodensity is associated with a bigger fiber area and also the higher percentage of centralized nuclei. We will be looking at these features in depth in next few slides. So in this example, we selected two patients from the extreme ends of muscle radiodensity. So on the first image is from, both images are females and a similar age, but the first image is from somebody who have a low muscle radiodensity, and in second image is from somebody who has a high radiodensity. You can, and in the image, the colors you are seeing, the green color represents the cell membrane, and the red color represents the fat content. In the first image, you can notice that somebody with the low radiodensity has actually a higher content of the fat, which we actually quantified. At the bottom, you can see the numbers. And also in the same image, but now we're looking at the different colors. Here, the dots, the blue dots here represents a nuclei. So in the first image, which is from a low muscle radiodensity, you notice that there are a lot of nuclei which are present in the center of those fibers. And also there is a difference between the fiber size. Somebody with a low radiodensity is actually having a bigger fiber size. In this colorful image, what you're looking at is a different fiber types. So again, with somebody with a low muscle radiodensity actually had a higher type 1 fibers, which we expected because type 1 fibers normally have more fat in them, and that might be driving this radiodensity in these patients. So one important feature which actually took our attention was the fiber size. So what we noticed that patients with the low muscle radiodensity were actually having a bigger fiber size, but in general, small muscle fiber size is considered as a sign of muscle atrophy, but it was opposite in this case. So what we did is we split the patient based on their fiber size and look at their characteristics. So here you can see in these two groups that there's no difference in the age, weight, or BMI or the Frail scale. But when we look at the clinical outcome, there was a significant difference between their performance in sit to stand. So somebody with a larger fiber size actually did a lower number of sit to stand. And with these exciting results, I would like to give it to Dr. Kedru to wrap these findings and to show our future directions.
Thank you. So this was really interesting to see the biology and see exactly what muscle looks like in these patients, which is very rare to be able to put together. And it makes us think about what could be our potential treatments and interventions, and specifically, what is the mechanism of the muscle wasting that can then allow us to prognosticate and then target in the future. And Dr. Negam, sitting beside us while he was a fellow at the Canadian Frailty Network, and also during his PhD was CIHR funded, and produced a network meta-analysis of randomized controlled trials ranking the management of frailty. We're currently doing this as a team, looking at specifically sarcopenia that we'll hopefully be able to get together in the next few months. But when he looked at frailty, it gives you some examples of what could be potential treatments. For example, what was ranked the highest was physical activity. And let me link that back to our muscle biology. When we have looked at the difference in fiber types 1 and 2, we may even change our BFIT program to be a more post-surgical resistive muscle training program compared to what we have right now. And we have been supported by CIHR Catalyst Grant to be able to do some modifications and also have patient engagement work with us to make this an ideal program. Other things that were ranked for treatment of frailty are physical activity, nutritional supplementation, psychosocial cognitive training, and pharmacotherapy. Our future work will be to look at the blood and urine samples that we collected at the same time and have them at the time of surgery, post-operatively, at multiple time points, and also at follow-up. And what we'd like to do is metabolomics on that and see if we can correlate this with our muscle features. Understanding the mechanism of the aberrant findings that we see in muscle, such as the increased fiber size and fat content that is seen in older patients, will be our future work also. So let me put this together. It's like putting pieces of a puzzle together. To be able to get, ideally, excellent outcomes in our surgical patients and the patients that you care for, it's going to be the clinical implementations that may be able to change it, such as our EASE and BFIT program. But we also see that radiologic characterizing muscle can have an impact on our patients. And looking at the biology assessment, I hope we were able to show you how rich that is to being able to direct what our future work can be for novel therapeutic approaches, not only pharmacotherapy, but also even in the type of physical activity and program that we assign and initiate with our older patients. And ultimately, that leads us to really exciting therapeutic interventions. So to summarize, our EASE clinical interventions have had a significant impact on reducing length of stay, major complications, death, and returning patients home. So please open up JAMA Surgery on February 12, 2020, and you can see all of it out of press. And then CT scans in surgical patients can provide an opportunistic approach to assessing muscle. And specifically, we showed you that muscle radiodensity can have worse functional and clinical outcomes. And older adults have this paradoxical relationship with muscle fiber size and functional outcome, which is very different than what we see with younger patients. Ultimately, it's going to be work combining our knowledge from basic science with clinical research that will really lead to novel approaches to caring for our older surgical patients and all of our patients in people's lives that you touch every day. So we have not only the two people beside me that I want to acknowledge that it's been a real pleasure to be able to work with their expertise, but we have so many other people to acknowledge as part of the team that we have on this slide, and you can go to our website to see more detail. And we'll hand it over back to you to see if there's any questions from the audience. And we encourage all and every question, because I'm not sure what time we're at, but we still have lots of time, so we're excited to answer anything and everything. Thank you.
Great, thank you. Thank you so much. Thank you to all of you. That was a great presentation and definitely a good way to kick off our 2020 webinar series. So I'll start off with a question while I wait for a few to come in into the chat box here. So I have a question. What extent of additional training or resources are required to identify muscle abnormalities using CT images?
I will take that. So one thing which we need is actually the software to analyze. That actually costs 5,000 Canadian dollars. And another thing is we need one specific person to analyze those images. There are new softwares which actually can automate it to do this analysis, but we still need somebody to actually look on those images that they are analyzed perfectly. So a person and a software, that's additional resource we need.
And potentially, if this was something that we used regularly in the clinics and our hospitals, this could be something that could easily be taught to the radiologist with the software. It could be something that I could envision seeing coming into our reports when we have the detailed reports from our radiology for our abdominal CTs. They could have another line that said sarcopenic assessment. So it is something that definitely there's a lot of people out there that have the aptitude and ability to do it. And for us, one of the cheapest ways to do it for our study was have the medical student do it. So even our medical student who we published in Surgery in 2014, he did that as a summer project. So it is definitely easy to be able to apply if we want to do that widespread.
Yeah, I really like considering that the CT has been already done and it's available. It's a great opportunity for any older adults who are going for CT image. So why not assess the sarcopenia as it shows that it's a major risk factor for unfavorable outcome.
Great, thank you. So one question here that's come in is sarcopenia associated with muscle radiodensity? Are these two abnormalities interrelated?
This is the question I always ask Dr. Buller. So thank you for asking that out there, because that is exactly what I ask him every time, and he tells me the details of why they're not exactly the same. So please.
So what we are seeing in the literature or in the cancer study that they are not associated, and then again, but those are a cross-sectional study, so we don't know if they are related over time. So we need some over time studies to find if they are related. At this point, we don't see any relationship between them. They are actually independent, strong predictors of outcomes. So if we factor in and adjust for each other, like they are independently predictors.
And as we see in most of the sarcopenia definition that has been published about the sarcopenia in older adults, like the European Working Group or the NIH group, the muscle radiodensity has not been included as a criteria. So most of them having, muscle mass, yes, physical function, yes, strength, yes, but not the muscle radiodensity. So I would agree. I think it's an independent factor, and as we just mentioned, it's an indication of how the intramuscular fat infiltration that might affect the muscle quality or muscle function.
And potentially in the future, if you actually did a literature search on sarcopenia, the literature out there in the past, even 7 years, 5 to 7 years, has exponentially increased just targeting sarcopenia, but really looking at the muscle radiodensity is not something that many groups have looked at.
Great, thank you for that. And another question here, which is a two-part question. So the first part is, what interventions can help treat sarcopenia? And the second half of that is, at what time point can these interventions be used in surgical patients?
Maybe Dr. Negam, why don't you do, because you did the whole network analysis, and currently we'll answer that question in a few months from really what the literature shows, but why don't you tell them what your experience has been for treatment? Yeah,
so as I said, like we are working with the psychiatrist teams about in sarcopenia intervention network meta-analysis, and from what we found, now we're included so far about 76 full texts, and as we're reviewing the full text, we see that Most of the intervention that's been used, there is exercise intervention, different kind of exercise, mostly resistance exercise. There's protein supplementation or combination of those. There is also some pharmacotherapy or anabolic hormones that's been used. So yeah, to know which one is the most effective, that's actually an interesting question, and that's why we're doing the network meta-analysis to see which one is the most effective and which one we should recommend to use for in people with sarcopenia. So yeah, stay tuned for that. We'll be out soon.
I can do the second part of the question. Ahead, sure. For the second part of the question related to when can we actually intervene on that surgical patient, when we think about elective surgery, we really think of a lot of opportunities that we can intervene. The population I was looking at in this group was specifically emergency surgical population. But for example, we have a study that was just funded by CIHR with Dr. Daniel McIsaac looking at prehabilitation and doing prehab prior to a patient having surgery. And we'll see what our study shows in a couple of years, but that's an example of where we can intervene. So prehabilitation, when we look at Dr. Vera Mazurik's work, who we're collaborating with, they're looking at omega-3 fatty acids and how can we actually use different types of supplementation and nutrition pre-operatively to be able to intervene on that surgical patient. And then all of those similar means we can use post-operatively, such as our BFIT program that we do immediately after surgery to prevent that muscle loss that happens every day if patient stays in bed. We can intervene there, and again with pharmacotherapy potentially, and other ways is when I looked at your network analysis is psychocognitive approaches, which can have an effect on frailty, and potentially that will hopefully address some of the other elements that come along with it, such as sarcopenia. So lots of really interesting ways that we can do it. But again, the biology and CT scans and understanding those components might be the missing link to this puzzle.
Okay, perfect. So maybe following up on those missing links. So there's someone who's asking, they're wondering about the role of genetics regarding fiber type and predisposition. Have you looked into anything regarding that area?
So in our population, we haven't looked at the genetics. That is something we know that affects the fiber types. In this population, the data we are showing is a very small sample size first. We have to see. And that, as we getting more biopsies, we'll have a bigger data set, and then doing a transcriptomics analysis side on side can help us answer that question. Yeah, that's a very good question.
Yeah, it'll be very interesting too.
And we've got another comment and question that's come in. One of the webinar attendees says, fantastic research, and they'd like to know if you have plans for looking at daily functional or mobility measures to understand functional recovery trajectories.
Say it one more time. I was so happy with the compliment.
Do you have any plans?
I was just happy with the compliment. It's been a lot of work, so we'll take any compliment we can get. So you want to know if there's, say it one more time and let me think about it.
I'd like to know if you have any plans to look at daily functional or mobility measures in order to understand functional recovery trajectories.
And one of the reasons I also needed to think about that is that that's a hard question. And I think that anyone who works in the hospital will recognize how difficult that is how do you actually measure how a patient is mobilizing post-op, and how do you document that? And in many centers, it's tough because I'll say our healthcare team is overworked with all the charting, and we just went to a computer system, so everybody's on the computer, and they're not as I don't know if I'm allowed to say it, but you don't see as much beside the bedside as we used to when you talk to nurses who are more senior of how much they would spend at bedside. But we are documenting a lot, and with our computer system, I just looked at Epic, and you can actually, there is a spot that the healthcare team can document when the first occurrence out of bed, how long out of bed, and they can document positioning, turning, and exercises within that system. So is it possible to do it? Yes. Is it, can it be done? Yes. And we just have to find the way to be able to work this into the workflow of our team. And that's a big grant that I'm working on right now, is implementation science. Is that we know that this is important work, but how do we actually implement change to be able to do that at the bedside? And we'll see. Our team's looking into that, and yes, there's ways to do it. And are we currently looking at specifically day by day? Not right now, but we will, and I think it's doable.
Great, thank you. The next question is just a quick clarification. Someone is asking, they may have missed this, but did you use a tool to measure frailty with these patients?
Yeah, so I think clinical frailty scale was there, so it has been used, and it's been presented in the CT images part. So we did use we did measure frailty.
And also, when the patients came back to our clinic, we did do the Edmonton Frail Scale by Dr. Daryl Rolfson. So we did 2 different frailty measures to be able to correlate. And if you look at our JAMA publication that's coming out soon, don't forget, you'll be able to see actually our frail scale that we used, and our protocol was also published in BMC Medicine.
Perfect. And then another question coming in. So someone's asking, first of all, they're saying, thank you for your nice and interesting presentation. They're saying that they just couldn't understand why the muscle fiber size is larger in the low radiodensity group, and why do you think that is?
So yeah, that was interesting finding, which we were talking about, that we wanted to look further into. So one thing which I think might be happening, because in the low muscle radiodensity, you have a more fat infiltrating in those fibers. That's one thing that might be making it a bigger fiber. Another thing is these fibers might be trying to regenerate, but you know, the area is increasing, but there's not enough nuclei to control that area. That's one. These are the theories which comes to my mind when I look at those things. But we still want to explore the mechanisms why that is happening. And that one of them is looking at their fat contents fiber type specific, to see if that is the case, because we know type 1 and type 2 fiber types actually behave differently.
It is really exciting finding biologically. This was an unexpected finding, completely paradoxical with what larger muscle fibers should do. So again, highlighting how important it is to be able to have this work and have the expertise is yours to be able to do that. So we're very lucky to see this.
Great, thank you. So that's all the questions that I've had come in for now, but to all of our webinar participants, you should be able to see contact information there on the screen, and I'm sure Dr. Kadaru, Dr. Buehler, and Dr. Negam would be happy to field or answer any questions via email anyone might have. And I'd like to thank Dr. Kadaru, Dr. Buehler, and Dr. Negam for their very interesting and relevant topic today that they shared through their webinar. As I mentioned at the beginning, we've got a webinar taking place next week at the same time, Wednesday, January 22nd at 12 noon. Again, that will be on supporting quality of life assessments of frail older adults and their family caregivers by Richard Sawatsky and Kara Shikmakarov. And once we wrap up this webinar, again, you'll see a post-webinar survey pop up on your screen. Please fill it out and provide us with your valuable feedback. And other than that, once again, you'll just see the contact information there should you have any additional questions. And other than that, we look forward to speaking with everyone again during our webinar next week. Thank you.
Thank you. Thank you.